Hello, we're from SGDB10 and we present about Stevens-Johnson syndrome. My name is Krisana Paramita Karnimaya with name 170. Stevens-Johnson syndrome is a rare severe cutaneous adverse reactions on the skin and mucous membranes such as genitals, eyes, and mouth that is characterized by cutaneous necrosis. Despite being rare, SJS can be life-threatening if left untreated. The mortality rate is 5 to 10% or even as high as 16.9%. The prognosis depends highly on the treatment's time frame, thus a time-effective treatment is necessary. In Indonesia, SJS accounts for 3% of all adverse reactions. Nevertheless, the treatment costs for some regions in Indonesia are still considered high, hence may serve as a barrier for patients to receive treatments. Therefore, Indonesian medical community should try to design a not only time-effective treatment but also cost-effective. A further understanding about SJS may serve as an initial step to plan a more cost and time-effective treatment. Therefore, this paper is written to further enhance the understanding about SJS by designing and answering such questions including first, what is Stevens-Johnson syndrome? Second, how are the epidemiology, etiology, and risk factors, pathogenesis, clinical manifestations, diagnosis, differential diagnosis, and complications of SJS? Third, how to treat and prevent SJS? And lastly, how is the prognosis for patients with SJS? The benefits of this writing are medical community can further understand about SJS, therefore may be able to design a more cost and time-effective treatment. Authors can enhance their knowledge about SJS and fulfill the student project assignment in the Immune System and Disorders block of Faculty of Medicine, Udayana University.
Hello everyone, my name is Puturai Natalia Anggreni with student number 217. So the definition of Stevens-Johnson syndrome is rare immune complex chains disease involving mucous membrane and the skin. It was first discovered and described by Albert Manson Stevens and Frank Cambliss Johnson in 1922. It is considered a minor form of TEN or toxic epidermal necrolysis by less than 10% of skin exfoliates. It can be severe form. Stevens-Johnson syndrome can lead to severe form called TEN or toxic epidermal necrolysis. Both Stevens-Johnson syndrome and toxic epidermal necrolysis are hypersensitivity reaction. Thank you.
Good afternoon, everyone. My name is Margo with name 057. I will present the epidemiology of Stevens-Johnson syndrome. Okay, both Stevens-Johnson syndrome or SJS and toxic epidermal necrolysis or TEN are uncommon disorders. However, they are severe cutaneous adverse reaction or scars which could lead to fast morbidity and mortality. Each year, the prevalence of SJS and TEN are known to be 1 to 6 cases for SJS and 0.4 to 1.2 cases for TEN per million people. The mortality rate for SJS and TEN were predicted to be 5 to 10% and 50%. Recent study estimated that Asians are more likely at twofold risk of SJS or TEN compared to Caucasian. Thank you.
My name is Inyuman Wigahayoga with name 109. I will explain about the etiology and risk factor of Stevens-Johnson syndrome. Stevens-Johnson syndrome can be triggered by the medication or upper respiratory infection such as herpes, hepatitis, HIV, or Mycoplasma pneumoniae, also malignancy or possibly idiopathic. The medication that may be precipitant are phenobarbital, carbamazepine, lamotrigine, sulfa-antibiotic, and NSAID. There are few risk factors that can make a person to develop severe cutaneous adverse drug reaction or scar. For the medication, anti-epileptic agent like carbamazepine have a risk of inducing scar. The condition of the host also contribute to the risk of scar. The example is underlying malignancy, the presence of systemic lupus erythematosus, and the presence of infection like tuberculosis or HIV.
My name is Vito with NIM 128. The exact mechanism of Stevens-Johnson syndrome pathogenesis is still speculative. Stevens-Johnson syndrome is thought to be a T-cell mediated disorder, and there are 3 hypotheses on T-cell activation: the Hampton-Prohampton model, the pharmacological interaction or PI concept, and the altered peptide model. The Hampton-Prohampton model includes the covalent binding of drug and their metabolites to carrier protein or hapten antigen. The PI concept includes the non-covalent binding of drug and their metabolites. The altered peptide model includes an altered endogenous peptide that can bind HLA-B5701. The damage in epidermis of the patients are thought to be of apoptotic origin. Apoptosis is induced through the fast-phase ligand pathway or the perforin enzyme pathway. Fast-phase ligand pathway includes the recognition of FASL, which includes the caspase cascade activation and resulting in apoptosis. The perforin or granzyme pathway includes the release of perforin and granzyme B by cytotoxic CD8 plus T cell, which includes epidermal damage in skin lesions. Thank you.
Hello everyone, my name is Putu Emilia Dewi with 3 last digit of study number 028. So I will explain about the clinical manifestations and diagnostic criteria of Stevens-Johnson syndrome. The SJS most commonly develops 2 to 8 weeks after drug exposure and is heralded by a prodrome of non-specific constitutional symptoms that occur 1 to 2 weeks before the onset of mucosal or skin lesion. The skin lesions, which may begin simultaneously or after mucosal lesions appear, consist of tender, red to dusky macules that are often targeted. Lesions generally appear first on the trunk, spread to the face, neck, proximal ends of the extremities, and palms and soles, and rapidly coagulate as you can see on the slide. Anamnesis of SJS was made to evaluate the precipitating factor of SJS. Meanwhile, the laboratory examination may be needed to find the relation of the precipitating factor and the patient's symptoms, also to find the correct treatment for the patient. The laboratory examination includes peripheral blood smear, immunology examination, and skin biopsy. SJS typically diagnosed only by clinical manifestations and some diagnostic criteria such as, first, the detachment of less than 20% of the body area in the first 48 hours of involvement, then develops to less than 10% of the body area as you can see on the slide. Second, typically and atypical iris lesions. Third, individual lesions less than 3 cm in diameter. Fourth, involvement of at least 2 areas of the mucous membrane. Fifth, mucosal involvement, most commonly intraoral, ocular, and genital, may occur with or without cutaneous lesion. 6. Fever. And the last, biopsy specimen compatible with erythema multiforme.
My name is Kamanjini Putri, number 031. Differential diagnosis. There are several differential diagnoses. The first one is toxic epidermal necrolysis or TEN. In TEN lesion, there are more than 30% of the surface body area. And the second one is staphylococcal scalp skin syndrome. In this syndrome, is there peeling of the skin surface, looks like burn with skin with hot fluids. The third one is erythema multiforme or EM. There are because of HSV infection and have 3 layers of target lesion. And then the fourth one is Kawasaki disease. In this Kawasaki disease, there are desquamation and non-exudative bilateral conjunctivitis. The last one is other drug eruption. In this eruption is there are pruritic or asymptomatic sign. Okay, that's all from the differential diagnosis. Thank you.
Hello, doctors and friends. My name is Giovanka Francia Purnama with student number 148, and today I will explain about the management of Stevens-Johnson syndrome. Basically, the management of this syndrome is divided into 3 steps, which is general measures, medical management, and management of sequelae. In general measures, we should withdraw drugs that induce SGS, and we should maintain the ambient body temperature. We should do fluid resuscitation and maintain the aseptic environment. Don't forget to change the wound dressing periodically and maintain urine output between 50 and 18 ml per hour. Sterilized banana leaf or umbilical cord mesenchymal stem cell transplantation can reduce the infection. In medical management, we can use some drugs such as steroids, which is dexamethasone, cyclosporine, tacrolimus, IVIGS, cyclophosphamide, plasmapheresis, IVN acetylcysteine or NAC, biologics drugs, and others such as recombinant granulocyte stimulating factor and GSF.
Hello, my name is Madeline, my number is 093, and now I will discuss about the complication of Stevens-Johnson syndrome. There are some complications that can occur in some organs after someone got this syndrome, such as in eyes, skin, respiratory, and GI tract. The manifestation in skin such as dyspigmentation, pruritus, nail loss, and hair loss. If in eyes, the examples are dryness, pain, and photophobia. In respiratory tract, the examples are dyspnea, cough, and while in the gastrointestinal are dysphagia and diarrhea. Although in some cases it can affect in the psychiatric side like depression, anxiety, and dyspnea can occur in post-syndrome. So that's all. Thank you, and the next presentation will be given by my friends.
My name is David, number 74. So I will tell about the prevention of Stevens-Johnson syndrome. So adverse drug reaction triggering Stevens-Johnson syndrome. So it's important to avoid taking the medication and other similar medications that triggering an adverse reaction to the patient. Another patient family member may get possibilities from a genetic factor to get a similar adverse reaction from the same medication, so they may also avoid that medication. If the patient has a history had Stevens-Johnson syndrome and has a risk to get it again in the future, it's important to look out for the symptoms. For Asian patients, it's important for genetic testing before taking medication that are known to have associated or high risk of causing Stevens-Johnson syndrome. The testing will help the patient determine whether she or he carries the gene SLAB1502 and SLB1508 that correlate with the syndrome when the patient taking the medication. Thank you.
Good evening. My name is Anish Sharma with name last digits 251, and I'll be talking about the prognosis about the Stevens-Johnson syndrome. Right, so for the prognosis, the recovery duration, it ranges from weeks to months, and also when it affects the skin which is affected may regrow in around 2 to 3 weeks, and after that there may still be complications, and the complications do have an impact on the quality of life thereafter, and re-exposure also can lead to reoccurrence, and it also can be fatal.
Good morning, Dr. and friends. My name is Shannon Kaista, name 051. Now we've come to the conclusion of our student project. So Stevens-Johnson syndrome, or SJS, is a rare semi-mediated disorder which involves mucous membrane and the skin. The prevalence of SJS is 1 till 6 cases over a million people each year, with a mortality rate of 5 till 10%. The diagnosis can be based on clinical manifestation, and there are also some diagnosis criteria. Some differential diagnoses of SJS such as 10, 4S, erythema multiforme, and also Kawasaki disease, with the complications of skin changes, cutaneous scar, dry eyes, and chronic fatigue. So it is important to avoid taking the medication and other similar medication that can trigger an adverse effect to the patient. However, recovery chances are vary from person to person. So that's all from SGDB10. Thank you so much, doctor, for your attention, and stay safe.